Today I'll demonstrate a movement that I commonly use as part of my repeated movement testing for complaints that are related to the lower cervical spine or upper thoracic spine, and sometimes it therefore becomes the directional preference that this patient needs to resolve his or her disorder. It's one of the top ones that I use for problems emanating from this part of the spine. And I say it that way because it doesn't necessarily mean the person has neck or upper thoracic pain, right? It could be something in the head, face, jaw, shoulder blade, shoulder, arm, down to the hand. This part of the spine is responsible for sensation to those parts of the body. So I'll demonstrate the procedure and then I'll give you a few notes on kind of how I use it. So from neutral, the patient retracts and extends and then holds it. For this particular directional preference movement, we more often apply it in a sustained fashion versus doing retraction extension repeatedly. But of course you can look at that as well. It's just one of those patterns we see in terms of what's most effective for joint derangements in this part of the spine. But here's a few notes. Some people cannot get very high. So maybe they're going up on their knuckles or even moving their elbows to kind of reduce the extension amount in the spine. But some people have a lot of motion. And for those patients, I'm having them put their elbows on folded towels or books to get even higher. So you want those elbows in a position where you can really maximize the amount of extension. And the person likely feels a strain because going to end range, which is what repeated movement testing is and directional preference movements are, is going to produce a strain to all the things around the joint, muscles in the front of the neck, etc. Now, one note I want to point out is I had a patient recently for whom his only complaint was shoulder signs and symptoms, including moderate to major losses of range of motion in the shoulder. And I looked at this for him in one of our visits, and I did 2 for 30 seconds, and then I retested the baselines of the shoulder, primarily the most restricted movement of the shoulder, and there was no effect. But because of his verbal history, because of his baseline presentation, because of his response to prior repeated movement testing, I went back and did it for 2 sets for a minute, and lo and behold, his shoulder motion was significantly, observationally better. So I think I would have missed this a few years ago. And so I'm saying this to point out that repeated movement testing is an algorithm that you get better at as a clinician the more patients you use it with, the more patterns you see, the more times you apply it. So sometimes patients, if I'm suspicious and I really think that the lesion, the problem is in this area, and I really think that the problem needs extension to get resolved, if I don't see something change in 2 for 30 seconds, I'll probably do it longer. But if I'm not suspecting that, I might abandon it then. So you have to understand where you're suspecting that the actual problem is and really kind of attacking that a little bit more aggressively to get your answer. And I've had patients do it for 2 or 3 minutes. Think about it this way. If the problem is here and that neck is flexed for hours a day, sometimes 2 for 30 seconds is not quite enough to get the answer you need. So as a clinician, if you're watching this, don't be afraid. If you really suspect and you've put together the entire pieces of the patient's puzzle, if you suspect there's a problem there, do more. In repeated movement testing, it's not just 10, not just 20, not just 30, do more to get your answer. With sustained 2 for 30 seconds might seem like a lot, but it can be completely insufficient, so do more.